Shreyanshi, we can start YouTube here, sir.
Okay, sir.
Yeah, now we are live.
Greetings and a warm welcome to all the dignitaries present here. I'm Sraushi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most reliable digital platform, offering a multitude of benefits and services exclusively for the doctors. It is with great pride that Planet serves as the digital partner for this event hosted by the National Neonatology Forum, Gujarat. And the focus of today's session is case presentation, Tracheo-Esophageal Fistula. So let's begin today's session, for which I would like to invite Dr. Kunal sir to take over. Over to you, sir.
Yeah, thank you so much, Shreyanshi. So, with great pleasure, we are continuing with our neonatal Pathshala series. And today we have a very interesting case about tracheoesophageal fistula. Dr. Ekta will be presenting that, and I would like to personally thank Dr. Pratima Anand Madam and Dr. Mitesh Bachani sir to have accepted our invitation for being an expert for this session. And so we'll don't take much of the time and we'll continue with the session. For further proceedings, our request Dr. Vishal Gohil, who is our project in charge. Thank you, Vishal, and over to you.
Thank you, Kunal. So first of all, I would like to invite our renowned faculties, Dr. Pratima Madam. She is one of the renowned faculty if I talk about the neonatology. She is a faculty at Lady Harding Medical College and Associate Hospital, New Delhi. She did the MD Pediatric followed by DM Neonatology from renowned center AIMS Delhi. She is also faculty at VMMC and Sabdaganj Hospital, New Delhi. If I talk about her achievements, she is lots of into the research and publication. She has already more than 50 publication, national as well as international, and also in the books. She is also like interested in neonatal intensive care, neonatal sepsis, neonatal research, and neonatal nutrition. And if I talk about her research, she is into the neonatal sepsis, growth chart, and IKMC. She is also NNF Delhi State Coordinator and National Trainer for Advanced as well as the Basic NRP, and National Trainer in the Pediatric Advanced Life Support and Basic Life Support. She is also national trainer in faculty-based newborn care, national neonatal trainer in preterm care package AIMS UNICEF. She's also like very much into the NNF organization. She's a conveyor and co-conveyor of the NNF National Education Module, like a Neo-Equip, Neo-Map, Neo-Equip, and the Neo-Shine. So I welcome Dr. Pratima Madam, and thank you so much for accepting our invitation. Now I would like to introduce our second faculty. He is Dr. Mitesh Bachani. He is also one of the renowned pediatric surgeon in Ahmedabad as well as in the Gujarat. See, he did the MS followed by MCH in pediatric surgery from GSMC and KM Hospital, Mumbai. He is also former assistant professor pediatric surgery BJ Wadia Medical College and Civil Hospital, and he is doing a private practice since more than 1 decade. See, he has a experience of pediatric surgery more than 15 years. So thank you so much, Mitesh sir, to accepting our invitation. Now, I am talking about the our presenter, Dr. Ekta Patel. She is a fellow in neonatology at Urban Newborn Care Center. She did the MD Pediatric from the VS Hospital. So I request Dr. Ekta to share her screen and start the session. I request all the faculty that if you have any question, you can interrupt her in between and ask the question. Over to you, Ekta.
Good afternoon, everyone. My screen is visible.
Yes, yes.
Okay. Uh, Good afternoon, everyone. I am presenting a case of a baby of a male child, single, born at 39 plus 1 week by elective LSCS on 16th November 2025, having a birth weight of 3.1 kg. Currently, the baby is 10 days old. and with a post of day of 10. Moving to antenatal history, maternal details. Baby is born out of a non-consensuous marriage to 34-year female, gravida 2, para 1, abortion 0, live 1 through a spontaneous conception. Her LMP was 14th February 2025 and expected date of delivery was 21 November 2025. Mother's blood group was B positive. First trimester, there was antenatal USG scan was done and gestation age was confirmed. There were no history of rash, fever, bleeding, excessive vomiting, no history of diabetes, mellitus or hypertension. Other blood test complete, blood profile viral markers were negative. Mother was on folic acid supplementation. During second and third trimester, mother was taking iron and calcium supplements. One dose of TD taken. There was no history of fever, burning, micturition, rash over body, no history of gestational hypertension or diabetes. There was no history of bleeding or spotting per vaginum or no leaking PV. Antenatal scan done at 22 week of gestation was suggestive of stomach shadow was small for gestational age with polyhydramnios. Last Doppler scan was normal. In natal history, baby was born. Baby was born by elective LSCS delivery on 16th of November at 9 a.m. at private hospital. Baby cried immediately after birth. The UPCAR score was 9 and 9 at 1 and 5 minutes respectively. The birth weight was 3.1 kg, which was between 15th and 10th centile, appropriate for gestational age according to the intergrowth 21 chart. Baby was shifted to our NICU at first hour of life in view of not able to insert the infant feeding tube and antenatal USG was suggestive of query esophageal atresia. Postnatal history. After admission, baby was maintaining saturation on room air without respiratory distress. Baby was having frothy oral secretions, so frequent suctioning of secretions were needed. Chest X-ray on admission was done after inserting infant feeding tube, which was suggestive of coiling of infant feeding tube in esophagus. Routine baseline investigations were sent. Baby kept NBM and full IV fluid was started and pediatric surgical reference was done for further management. The routine USG head and KUB was done, which was normal, and 2D echo cardiography screening was done, which was normal. Here is the X-ray of the baby on admission. On day 2 of life, the PICC line was inserted and baby was operated on day 3 of life. By the right posterolateral thoracotomy was done and fistula was ligated, and then end-to-end esophageal anastomosis was done over 6 French feeding tube. 12 French suction catheter was kept as a drain. Post-operative course. Baby was vitally stable with maintaining saturation on room air without distress. Baby was kept NBM for 6 days. On 7th day of life, dye study was done, which was suggestive of no leak, and it was normal. So RT feeding was started on from day 7 of life, and gradually it was increased. Currently, baby is on RT feeding around 135 ml per kg per day and raised IV fluid. Total fluid administered is 150 ml per kg per day, and baby is receiving currently energy of 108 kilocalorie per kg per day and a protein of 1.5 gram per kg per day. Summarizing my case, the full term 39 plus 1 week, male child having birth weight of 3.1 kg, appropriate for gestational age, with the operated case of tracheoesophageal fistula type C, having on the post of day 8. Ma'am, should I move toward the examination part?
Yeah, a few questions. So, while you took the antenatal history, what were the things which you kept in mind once you got to know that there is polyhydramnios and a small stomach bubble? Anything else specific you want to ask in terms of risk factors for these things? TEF?
Uh, Ma'am, in risk factor, I have to ask about diabetes mellitus,
Yes.
or any uh, history of fever, then other the anomaly scan, and the first trimester screening. We have to ask about it.
Yes, so the risk factors are basically either chromosomal or genetic issues. So are they sporadic or is there a recurrence rate? What about the obstetric history? There is a one live issue, I think. What about that baby? He's healthy? The first previous live issue?
Yes, ma'am. The first baby was full term delivered. With the delivery was LSCS, around 3.5 year of age, female child, and the previous baby has no any significant history.
So these are sporadic cases and the recurrence rate is less, है ना? इसलिए
Yes,
इतने
ma'am.
numbers. So rightly said, maternal diabetes, some maternal infections have been linked. Any medications the mother was on? Any medications which may be related to such things, malformations like these?
No, mother was not on any medication, ma'am.
Okay. And second trimester में what all can we do to rule out trisomies, if at all?
Yes, in second trimester, ma'am, we can do the second trimester screening by biochemical profile. Four biochemical markers we do: unconjugated estradiol, inhibin A, beta HCG, and maternal phyto alpha protein. And along with it, we have to do for the we can see for the anomaly scan.
Right.
Nipple translucency we can see in a first trimester.
So, looking at the case after birth, so how would you prognosticate the family? Well, what are the does this baby pre-operatively have a good prognosis or a bad prognosis? He was operated on day 3, but even before the surgery is done, what all indicators are there which would indicate whether the prognosis is going to be good, bad? How would you decide whether primary anastomosis should be done? Any other features which you can indicators which you can tell?
Yes, ma'am. In We can do primary anastomosis if there are atresia esophageal, the gap of the atresia is high or short gap. The high gap has a, poor prognosis, and also if baby has any associated anomalies, then like cardiac anomalies or any
So in
vertebral.
this particular baby, the good prognostic features were he's a term baby, 39 week, good weight baby, on room air, even pre-operatively. Plus the gap, high and low, how do we decide that?
By the if the it by the distance between the two pouches, if it is around more than 2 centimeter, by calculating the vertebral bodies.
Vertebral bodies. Okay. Okay, and no other comorbidities like any other vertebral genital anomalies?
No, ma'am. In this baby, there was no any
No
no,
neonatal morbidities also like RDS or respiratory support
no,
need,
ma'am. No,
sepsis, shock, nothing of that sort was there. No? So
no.
those are some of the indicators that yes, pre-operatively he was okay, good place for surgery. Right. Okay. Anything else, Mitesh sir? You can please.
Please continue.
Okay, sir. On examination, baby was nursed under a servo control radiant warmer, set temperature with 36.5 degrees centigrade with a cap, 6 French OG fixed at 24 centimeter. Temperature probe attached to left lower part of chest. Baby is alert with pressure stage 4 and in supine position. Peripheries were warm and pulses well felt. PICC line in situ. Vitals, baby temperature is 36.7 degrees centigrade, measured in the axilla. Heart rate is having 148 per minute with a good volume and regular rhythm. having a respiratory rate of 46 per minute and abdominal thoracic of type, maintaining a saturation around 98% on room air. Blood pressure was 74 by 52 diastolic in the with a mean of 59, which is more than 15 centile, and capillary refill time over the sternum and was less than 3 seconds. Anthropometry of the baby. Baby is weighing 3.1 kg. It is between 15th and 10th centile. Length is 49 centimeter, which is just below 50th centile. And head circumference was 33 centimeter, which was between 15th and 10th centile. Baby is appropriate for gestational age. In head-to-toe examination, the baby's color is pink with the anterior frontal open at level, measuring 2.5 by 2 centimeters. Sutures are open, skull shape normal. There is any no facial dysmorphism, umbilical is centrally placed. Suture is present over the operative side, which is curvilinear and having no any redness. Genitals are normal. Anal orifice is patent and back and spine is normal. Uh, in the respiratory system examination, baby is on room air. Baby is comfortable with respiratory rate of 46 per minute, having no retractions and preductal saturations of 97% on room air. On auscultation, the air entry is equal on both sides. The gastrointestinal system, the umbilicus is healthy, no organomegaly, and bowel sounds are present. Cardiovascular system, the baby has mild pallor with heart rate of 146 per minute with peripheral pulses palpable, regular rhythm. The femoral pulses are palpable bilaterally. The CRT is 2 seconds at sternum and peripheries are warm. Apex impulse located over fourth intercostal space medial to the mid-clavicular line. Heart sounds are normal and no murmur present. In central nervous system, baby is in a pretal stage 4 with the cry and habituations normal. Movement of all four limbs are present. In cranial nerve examination, there is no any abnormalities were found. In motor examination posture, the baby was upper limb was flexion at shoulder and elbow, and with the lower limb flexion at hip and knees, bilateral symmetrical. Passive tone, the scarf sign was arm not crossing the midline. Square window was around 30 degree and popliteal angle was 90 degree. Active tone was not performed on this baby. The diaphragm and reflexes were +2. In reflexes, Moros was not performed on the babies due to post-operative conditions. Palmar grasp, rooting, and sucking reflexes was observed and it was normal. So diagnosing my baby is 10-day old, full term, 39 plus 1 week with a 3.1 kg, appropriate for gestational age, born after cesarean delivery, having a tracheoesophageal fistula type C, and currently baby is is having a post of day 8. Uh,
Ma'am and sir, you can ask the question, ma'am.
Okay, I think well presented. Mitesh, sir, you want to ask first, sir?
Yes, one quick question. How would you transport this baby and what are the precautions you are supposed to take during the transport and during the pre-operative phase?
Yes, sir. During the transport and pre-operative phase, we have to prevent the aspiration of the secretions. The head can. We have to keep the head at around 30 degree 30 degree centigrade elevated. Suctioning should be done, but it should not be very deeper. Uh, uh, Around we can use the continuous suction also. Then the neck position, um, that's it.
Suppose
Yes.
if you are asked to transport a baby from a remote location, what are the instruments you are supposed to take along with you? And
Uh,
what would you ask to the clinician what is the condition and what are the reports you would ask beforehand?
Yes. Before transport, we have to ask about any other congenital anomalies. Then we have to carry the suction catheter and suction instrument. Uh, to clear out the secretions, we have to keep the baby neurothermic during the transport. Um, the-
Can you put the baby in prone position to avoid aspiration of saliva?
yes, we can put.
Okay, and you said continuous suctioning. What is that method or what is the special tube which you are preparing for continuous suction?
The catheter has multiple holes at the end for the suctioning, and it is named as a Replogal catheter or Vigan catheter.
Okay, so can you prepare it in your NICU?
Uh, yes, sir. We can in a suction catheter tube. We have to do the we have to create a multiple holes at the end of the catheter.
No, it's not like that. It is you. Uh, I'll just explain what we used to do. Take 10 French feeding tube. Okay. Make a hole approximately 15 centimeter from the tip. Okay. And insert number 5 feeding tube within number 10 feeding tube. So there are in pharynx, you will have double tubes, the outer tube and inner tube, and you will attach the suction to the inner tube so that the pharynx doesn't collapse. That is known as Repogli tube.
Okay.
Yeah. And how about NICU? You have done echo. Suppose the child is having cyanotic heart disease. How will you proceed?
In this baby,
No, suppose this child was absolutely fine. His heart was normal and he was on room air maintaining well. What if the child is having cyanotic heart disease?
okay, we can do initially we can keep the baby nil by mouth, and we can put a gastrostomy tube, and feeding can be started. Then
No, there is a
after.
fistula. No. I am just not talking about surgery. What would you do if you have received a child with tracheoesophageal fistula and something that is dangerous to his life is cyanotic heart disease, right? The
Okay.
tracheoesophageal fistula is not going to kill him immediately, but that cyanotic heart disease or severe respiratory distress. So what will you do in that scenario?
Uh, for ventilation, we can intubate the baby, but we have to properly intubate the baby, and keeping in mind that the endotracheal tube should be below above the carina, and we have to check that it is not gone into the fistula, and the abdominal distension is we have to avoid the abdominal distension.
Okay, that's fine. What I would say is I'll call a pediatric cardiologist. I will let him evaluate the child. I'll ask for his opinion. Whatever, if you need to intubate the child, you will intubate the child. You need to start some inotropes or some other medication. You will start all those things. But the thing is, the prognosis would be different in this child.
Yes,
in your child, the case you presented, prognosis was excellent. So you
yes.
could safely say that most of the time the child will do fine. He will tolerate the surgery and post-op, most likely outcome will also be uneventful. But in that case, you have to be ready. You have to explain the parents before doing anything that these are two different things and the prognosis will be not as per expectations. Okay, now the surgery is done. Have you witnessed the surgery? Any tracheoesophageal surgery?
No, sir.
Okay. So another thing which I would like to highlight, I don't know whether you can put the tube beyond fistula so as to avoid excessive distension of stomach. Whatever I have seen during surgeries, first, it is not absolutely essential, and two, you will not be able to put it exactly before in the proximal to carina and beyond fistula. Even though if you put it beyond fistula, it is air, it will pass everywhere, right? So as per surgeons, it is not mandatory. I don't know about neonatology forum or pediatric forum, but I have repeatedly heard this thing that you put the tube beyond fistula and proximal to carina. It is not possible. If the child is especially smaller, less than 2 kg, almost always the fistula is in the vicinity of carina, right? It is within 1 centimeter of carina, almost always. It is very rare that it opens somewhere high and you can do such things. Okay, second thing. What are the precautions you will take post-operatively?
Post-operatively, we have to maintain the neck position of the baby. Then we have to
What
see.
is the what is the exact neck position? You are keeping the baby in certain position. What is that position?
Uh, we keep the baby in a supine position with the head around 30 degrees centigrade elevated. Uh,
No, it is simple. You are not supposed to extend the neck. That is it. You keep the baby as it is, and I would recommend little anti-G reflux posture. You keep the baby head high position at least 15-30 degree, so as to the baby swallows the saliva easily and it goes into the stomach. This is the position. What about the intercostal drainage care? What would you observe?
we for we have to see for the any uh, leak from the anastomotic site. Uh, it can be present post-operatively. So we have to put the drain, and also we have to see about any air leak. So the drain is there.
I'll explain. We put intercostal drain for two reasons. One, because we have retracted the lung, we have opened the thorax. There are chances that child may have pneumothorax post-operatively. So to avoid pneumothorax, that is number one. And number two, there is an intestinal anastomosis, right? Esophageal anastomosis. And usually whatever major leak that occurs is after first 48 hours. Okay, so on day 3 of post-op day 3, you have to be alert. What we see as surgeons is whether saliva is coming, any frothy material is coming in the tube or not. What is the column movement? Usually by 48 hours, lung is fully expanded, column stops moving. If column continues to move, that means lung is not fully expanded, right? And two, if frothy material is coming, then that means the child has started, the anastomosis has started leaking. One more thing, if sometimes anastomosis opens up with a major leak, child may develop pneumothorax. Your ICD may be blocked, so it is not showing any column movement, but the child will have respiratory distress. So you have to be alert in post-op phase for one, that is leak, and two, developing pneumothorax because of leak. So these two things you have to be very careful. And apart from other vital parameters and monitoring temperature, vitals, sugar, and nutrition, every aspect. Madam?
So, Ekta, when would you like to start feeds in this baby? Complications very nicely covered by Sir, I think. I was going to ask you about as a neonatologist in an ICU, what all precautions would you be taking to prevent these complications? So, Sir has explained those. So, now coming to nutrition part, so how would you anticipate or how would you start feeds in this baby? When would you like to start feeds in such a baby, post-op baby?
Ma'am, after the dye study, if we after the dye study and they confirming that there is no any anastomotic leak and baby is vitally stable, and there is no any, then we can start with the feeding. We With the RT feeding we can start. For feeding we have to keep in mind that the reflux, because there is more chances of the reflux post
Do you
operatively.
do dye study in all the cases, sir, mandatorily before starting feeds? Here we do not.
Yes,
uh,
we do in all cases.
Okay. Okay, okay. Tell me how much amount would you start and what would you assess for?
Ma'am, after starting
What are
the
the signs
feed.
of GERD which you are thinking that okay, some babies may have the complication, GERD as complication?
Yes,
Yes.
ma'am. After starting the feed, if baby is having a reflux, but baby is vitally stable, there is no any cyanotic spells, or no any respiratory distress is there, we can continue with the feed. And if it is more there is more episodes of cyanosis and respiratory distress is there, then we have to uh, start the pharmacological treatment for the GERD. If there is also, if the baby is not gaining proper weight on full feeding.
So what kind of feed is the baby on and when did you start the feeds in this baby?
Yes, ma'am. We started the feed on post of day 8, ma'am. After the post of day 7, after the diet study, ma'am. Currently, the baby is on mother milk and on top milk, ma'am.
Okay. So how frequently are you collaborating with the surgeons? Are they monitoring the baby every day or every alternate day? What should be the collaborative effort between a surgeon and the NICU team in this particular case?
Ma'am.
How would you follow up? In other words, during the NICU stay and also when you're planning the discharge for this baby, when would you be planning the discharge and what all collaborations would you be doing with the surgical team?
Ma'am, during the NICU stay, we are collaborating with the pediatric surgeons in mostly daily basis. While discharging this baby, at the time of discharge, we collaborate with the pediatric surgeon, and during the discharge, when the baby is on on complete mother's feeding, or with the breastfeeding, or breastfeeding and tolerating the feed, we can discharge this baby. Post discharge, on a follow up, we have to see for the weight gain, any major complaints, like is there any difficulty in feeding, or choking, or cyanotic episodes, or baby is having a difficulty in feeding.
Okay, now one hypothetical, this baby was perfectly fine without any hindrances in the post-op recovery. So what if such a baby or maybe perhaps a preterm or a low birth baby requires ventilation post-operatively? What are the precautions in particular for ventilating such a baby post-op tracheoesophageal fistula?
Yes, ma'am, we have to keep the pressure, lower pressure, and
Yes.
lower pressure, and the rate should be oh, sorry, ma'am.
Gentle ventilation, you're right. Low pressures as far as possible. Adequate PEEP. Follow up with the X-rays because there can be some compensatory hyperinflation. There can be patches of atelectasis. And volume guarantee, if you are using, how much volume would you keep? And how much would
Um,
you avoid?
Yes, ma'am. In this baby, yeah, we can give 4 to 6 ml per kg. But generally, if this baby is having a post-op case, then I would like to use 4 ml per kg of the volume
Yeah,
guarantee.
avoid over distension of the lungs as well as the abdomen. So don't go more than 6 ml per kg. And keep the stomach always, non-distended. Even if you're weaning, can you use non-invasive ventilation in these babies post-op?
Uh, no, ma'am. In this baby, we had not used.
Not in this baby. In post-op test babies,
Yes, ma'am. We can use.
it was okay pre-operatively, post-operatively. So yes, you can use, but take care that your tube is, your gastric distension is not there. Even there, the pressure should be cautiously used, and assessment monitoring is important.
Yes.
Okay. Any other precautions you would like to take? The site of suture and all that precautions. So how are you looking after that?
The wound infection. We
What
have.
all are you doing daily? You must be seeing the baby daily, taking care of the baby. So what all simple things you are doing to prevent the local infections, and how are you taking care of that?
Generally, no, hand hygiene should be done properly. Then the we generally keep on check with the dressing and change the dressing regularly. Um, and the topical uh,
Okay, so that should be spoken more precisely, perhaps daily ones, or what local antiseptic you want to use, so that you can tell.
Provident, we use the betadine ointment for the local antiseptic.
And how would you suspect any recurrent fistula if it is there? Possibility of recurrent fistula? Have you
That
discussed it with the surgeons? What can be the danger signs or the red flags that possibly there is recurrent fistula, especially in end-to-end anastomosis where it has been done?
there are more chances of recurrent fistulas are there. The baby will again will start having complaints of recurrent episode of respiratory infections or distress or pneumonia. The baby will start will have the aspiration of the food.
फूड तो नहीं मिल्क ही होगा ना इसमें न्यूनेट्स
Yes, yes.
न्यूनेट्स
Milk.
Mitesh sir, anything else to add, sir? How we can suspect bedside any recurrence of the fistula or
Then a recurrence of fistula usually happens after a leak.
Hmm.
So if your esophageal anastomosis is intact and you have closed the tracheal end of the fistula properly, then there are no chances of having recurrent. That will be H type of TE fistula,
Okay.
right? If your anastomosis has leaked, that means you are prone for developing a recurrent tracheoesophageal fistula because of that leakage and the infection that sets in, and that will erode your suture line on the trachea as well. So that is one thing. Whenever the anastomosis is very tight, it is under tension, there are higher chances of leak and there are higher chances of re-TEF. Second thing, recurrent TEF occurs when there is a severe degree of anastomotic stricture and you are dilating it again and again. Right? In these cases, there are higher chances of having a recurrent tracheoesophageal fistula. Again, how we diagnose? One is clinical symptoms, aspiration, pneumonia. If the fistula is large, classic H variety, then stomach distends when the baby cries because gas passes in the esophagus as well as. And we do dye study, that is prone tube esophagogram. What we do is we insert a tube in the esophagus. We take the baby in the fluoroscopy suit. We do dye study in prone position, gradually withdrawing the tube while injecting the dye. And at D4, D3, D4, 5 level, we inject and then we see whether there is any leak or not. Because trachea is anterior, esophagus is posterior. So we do it in prone position. This is how we detect. And final is bronchoscopy.
Yes, bronchoscopy.
We do bronchoscopy and we confirm. Sometimes, even in bronchoscopy, the native fistula, we don't like it sometimes flush to the trachea. So we may see a dimple at the site of native fistula. That may look like a recurrent TEF. But what we do is we do rigid bronchoscopy, we inflate the trachea fully, and then we try to pass a guide wire into that opening. If it goes, that means it is a recurrent F. This is the confirmatory thing for recurrent F.
Thank you, sir. I think Ekta, for follow-up, we also need to monitor the weight and the growth faltering part also, because as we have seen, GERD is one of the complications, and we need to ask the parents, tell the parents about the adequacy of feed, whatever he's taking. So that is important on follow-up.
Two One more thing for follow-up. One is what are the signs that baby is having a stricture of esophagus? It may happen within 2 weeks,
Yes, subacute kind of thing. Yes.
right?
What will you tell, Ekta? Sir is
Yes.
asking. Yeah. Sir is asking you, when we explain the follow-up care to the mother, so how would you explain the signs of stricture? The stricture may develop after 2 weeks post-op. Right now he's 1 week, he's accepting feeds well. So any other signs you want to tell the mother to look for?
For mother, we have to explain about is there any difficulty, baby started any difficulty in feeding recently, then baby is having feed coming having a feed regurgitation is there, then is baby develop any respiratory distress, like we can explain them the baby is developing coughing or increase in rate of respiration or work of breathing.
Vomitings, somebody has it.
The first thing, when the baby develops stricture, baby will not be able to swallow properly,
Yes.
right?
Yes.
So one thing, he may regurgitate feed. Second thing, it will take longer duration for feeding. These are the very early signs. If you are feeding him 50 ml bottle and the child is finishing in 20 minutes, then it may take longer. Sometimes child may be uneasy because he feels choking sensation. Because the feeding is inside his throat, it is unable to swallow it. So these are the subtle signs in early phases of stricture, when you would be able to, the parents will be able to pick up these things, that child is having some issues regarding to feeding. Vomiting is more or less a sign of GE reflux. Almost all babies, almost all, I may be little on higher side, they all have GE reflux of some sort, right? And what I would recommend is first phase of aspiration pneumonia after TEF surgery, or first phase of choking after TE fistula, you should go for fundoplication, right? Even in recurrent strictures, you should always keep in mind that because this is recurrent stricture, you have dilated once, twice, thrice. If it is within few weeks of duration, then you are supposed to tell the parents that you may require surgery, fundoplication, because that is one of the contributing factor for restricture. So we have very low threshold for fundoplication, especially after TE fistula surgery, because what we have seen is one episode of choking, the child will die. Whatever hard work you have done in ICU and in the surgical room for 2-3 weeks, you have worked hard, baby goes home, and you will listen from the parent that while feeding, child died suddenly. So this should not happen. That is, you have to sensitize the parents regarding follow-up care. The subtle signs that may suggest that child is having stricture, child is having high degree of GE reflux, the failure to thrive and poor weight gain, all those things are little later, right?
Yes.
So that's it.
Life-threatening things should be told, the danger signs, the red flags, especially the complications which can occur 2 to 4 weeks after surgery, as sir told. And long-term in follow-up development, faltering, all these things need to be seen. To complete the academic discussion, Ekta, would you like to elaborate on the types of tests? And this baby had type C. So
Yes.
how would you grade the various types in terms of prognosis? Again, the clinical course, something of that sort. What's the difference? Can you just briefly discuss those? Many of those sir has already told, like H type, what will they be having, and C type already this baby has. So just elaborate
Uh,
on that, please.
Yes, ma'am. There are type A to E. Type A is only esophageal atresia. Type B is having proximal tracheoesophageal fistula with distal atresia. Type C, which is the most commonly seen, is a distal fistula and proximal atresia. Type D is proximal and distal, both tracheoesophageal fistula without any atresia, and types E is uh, there is a fistula only and no atresia is there. In terms of
Associations, prognosis, any
yes.
on that? How would you anticipate and what would you suggest? Yeah.
Yes, ma'am. In type A and B, when there is a fistula is proximal and there is a no fistula, we can identify by there will be no any gas shadow in X-rays. The prognosis of the type C, which is more commonly seen, around 85% in all the babies, is uh, having a good prognosis. The type A is more commonly seen associated with the syndromes, more commonly associated with the trisomies 18 and 20, more commonly in trisomy 18. The association with the other syndromes are vectoral associations. There will be charge syndrome. Feingold syndromes can be present in the babies of tracheoesophageal fistulas.
Okay, I think Dr. Vishal. Uh,
Yes, ma'am.
yes, I think.
Yeah, there is a one, I think, question to the Mithas sir actually. What about the Tracheo Malaysia? I think we are just also
Yes,
everyone we are talking.
I was
Uh,
about to ask that question.
okay. So that is the academic purpose. Like when cut down the fistula, we always worry as it is about the fish, this Malaysia, Tracheo Malaysia. It's not about the surgical skill, but you are going to cut the cartilage and it is going to be damage the natural structure. So how will we deal with that one? Actually, because most of time we take as a reflux. Most of time we are taking as a the different diagnosis. But trichomalacia is a part of the TO fistula post-operative or different else. How will you
No,
approach
no,
that
no,
one?
no. The tracheomalacia can be pre-op as well as post-op. Hello, am I audible?
Yes, sir.
Yes, sir. Yes, sir. Go ahead, sir.
Tracheomalacia can be pre-op, can be post-op, right? Uh, what one hypothesis is that the upper pouch, which gets dilated because of the atresia, upper esophageal pouch, that causes compression on the trachea and it causes some
Okay.
decalcification of tracheal rings, so they become softer. This is one
Okay.
hypothesis. God knows what is the exact reason. But uh, during surgery, some things may affect the trachea in early post-op phase, not for longer duration. That
Okay.
is, sometimes if the upper pouch is very high, we have to dissect a lot along the tracheal wall. So during that dissection, trachea is handled little on the higher side, and we need to retract trachea sometimes with our retractors. And there is endotracheal tube, so the mucosa gets compressed, but that is immediate post-op phase, right?
Okay.
And regarding, we are not cutting any cartilages,
Yeah,
okay?
yeah,
During
behind
surgery,
that one, yes.
no, no. What we are doing is we are dissecting the fistula, we are dividing the fistula, we are ligating it on tracheal side with absorbable sutures, and that's it. We are not cutting any cartilage.
Cutting, yeah.
So
Okay.
yeah, so few things we don't know why they happen, but tracheomalacia, if it respiratory distress because of tracheomalacia which lasts little longer, it is not because of surgery. Whatever surgical trauma, edema, whatever happens, that lasts for probably maximum 1 week, not beyond that. If there is leak, if there is sepsis, that is a different story. But otherwise, surgery doesn't affect tracheomalacia.
That much. Yeah.
It doesn't cause tracheomalacia.
Anything, madam, from your side? Anything inputs regarding the tracheomalacia? Because in our private center we are facing few patients, but because of our surgical expertise, sir, we never face but few cases in last 10 years. One or two cases we faced the tracheomalacia. Of course, that was the pre-op, and it is not because of the post-op, but definitely it affects a lot. Sometimes baby end up with the bronchoscopy. We need to do the virtual bronchoscopy, and baby is all throughout fine. Within a few months, baby will be okay, and the workup breathing and everything is gone like anything.
There may
I
be
think,
subtle, there may
yes,
be
yes.
subtle micro aspiration.
Yes. Thank you so much. I think, madam and the sir, I think your inputs are excellent over here, and we enjoy the discussion. Thank you, Ekta, for the wonderful presentation. I would like to request our faculty to give a few key messages regarding the TO feature, like one line or something like that. So that will keep on our mind, because there's lots of new thing. I think I must say there's a few things which is also new for the delegates over here, and also helpful for the treating that patient in future. Prati madam, first from your side. Prati madam. Madam, you are mute, ma'am.
She has left probably.
I think so. Okay, Mitesh sir,
He
you
is there,
can
but
just.
yeah.
What I would say is all type C should survive.
Yes, sir.
All tracheoesophageal fistula with type C must survive because they all are salvageable and they all have excellent prognosis. Okay. Second thing is, in post-op care, just be mindful about stricture. They are very common, and aspiration and G reflux. If need arises, consult surgeon. Do G reflux, fundoplication as early as possible.
Thank you so much, sir. Kunal, anything? Do you want to put anything?
I think
Any?
it was an excellent case presentation. The discussion also went very well. So thank you to the Tech Ekta for the excellent presentation and for the wonderful discussion by Dr. Pratima ma'am and Dr. Mitesh sir.
I think we can end the
Yeah,
session. I think
yeah,
Pratibha might be left. Thank you
yeah.
so much, Mitesh sir. Again, thank you, Kunal. Thank you, Ekta. And we can end the session. Bye. Thank you.
Bye.
Thank you so much, everyone. Thank you. So, with all the permission, I'm ending the session.
Yes.
Thank you, sir.
Thank you. Bye.